some reason.
Is at the top of the UP, no?
Hope it is not from our side.
No, I think
Abhishek?
this some problem. I log out and
We are live now, ma'am.
Okay. Rashmi, we can go ahead.
Yes, we are live and we are about to start. A very good afternoon to all the respected dignitaries and faculties, guests of honor, special guests and faculty, respected chairpersons. I extend a very warm welcome to all of you for this webinar. The theme of the webinar is hyperglycemia in pregnancy. We are very delighted to present this webinar in association with Obstetrics and Gynae Societies of Hyderabad, Karimnagar, Khammam, Mahabubnagar, Mancherial, Nalgonda, Nizamabad, Warangal, Srinagar, Jammu, Wayanad Obstetrics Gynae Society in association with Deoli Sawangi OBGY Society. We welcome all the dignitaries and I would request all of you to kindly join for the online inauguration of this webinar.
Abhishek, sound.
Sound, Abhishek. Thank you very much. The convener of today's webinar is Dr. Surekha Tade. She's Professor Unit in Charge at JNMC Sawangi, Wardha. She's a teacher, mentor, and guide with a lot of experience in clinical research and very high aptitude for community projects. I would like to ask Dr. Surekha Madam to kindly introduce and welcome all the chief guests and the dignitaries.
Thank you, Dr. Rashmi. I am Professor Surekha Tade, and I take this opportunity to welcome all the dignitaries on the dais. Special welcome.
It's frozen, madam's frame. Yeah.
The voice is not there.
I think internet connectivity.
Surekha ma'am, your might be your connectivity is the issue.
Yeah.
Anupam, hi, meanwhile.
Hi, madam.
Hey, Nori Take wale mein, you're drinking the tea in that Nori Take cup?
That's it.
That's it. Hi, Varsha.
Hi, hello.
Hi, Dr. Atul sir. How are you?
We've been seeing
Sir,
all
fine.
the photographs of the wedding, Varsha, and enjoying them.
Yeah, thank you so much.
Lovely, fantastic.
Thank you so much.
वर्षा मैम नमस्कार.
नमस्ते जी, कैसे हैं आप सब
बस
लोग?
आपका आशीर्वाद बहुत बढ़िया.
Thank you.
How is Agra? Hot?
हाँ sir, hot. Very hot. It's 45 degrees today.
The sun is there today in Agra. Sujal.
अनुपम जी, कैसे हैं आप?
बहुत बढ़िया. गर्मी बहुत ज्यादा है. I think Dr. Surekha, we have.
I got disconnected because there was a power failure in my area. I go ahead and I would like to welcome all of the
Again problem.
Dr. Atul sir and all the guest of honors. The speakers for today, Dr. Kinanmay and Dr. Mitra Saxena, hearty welcome to you. Our expert, Dr. Ritu Joshi, and our chairpersons, Dr. Anupam Gupta sir. Then we have Dr. Shailaja Akula, Dr. Nikat Firdos, and we also have Dr. Aruna Suman, Dr. Pradnya. We have Dr. Amita Gupta from Jammu. We also would like to welcome our expert for the panel, Dr. Krishna Kumari Meka ma'am. Then our panelists, Dr. Arjuna Singh, Dr. Manasa Devisani, Dr. Sabita, Dr. Shehnaz Tang, and Dr. Kiran Trivedi and Dr. Omana. We would like to inform the August audience that this is our 25th webinar of ISOPAR Vidrup chapter, and we have been conducting these educational activities throughout the country. In fact, we have covered whole of the South. We have gone to Kerala. We have done 2 webinars in Karnataka, 2 in Tamil Nadu. Then yesterday we did with Andhra Pradesh. Today we are doing with Telangana. Then we also had in the north, we did 2 webinars in Uttar Pradesh, then Haryana, Punjab, Northeast we covered. We also did in West Bengal. So that is how we have, gone, we called it Tour de Telangana and Tour de Kerala. So we are touring the country because we want to learn from all of you esteemed faculty and share whatever we have with us by organizing these webinars, especially on women's health and especially special interest in taking care of maternal lives and high-risk pregnancy. So here we are today with the theme of hyperglycemia in pregnancy, and we would like to introduce our chief guest for today, Dr. Atul Munshi sir, to the August audience. We all know Dr. Munshi for his great scholarly and academic aptitude, and we have seen he is an institute in himself. The way he has, conducted the scholarly activities right from when he was the professor and head of GCS and NHL Medical College. He has been mentoring so many of the students, and we have seen him as the senior vice president of FOXI in 2007. And after that, we have also seen him as the chairperson of ICOG in 2014. He's also been active in IMS, as being the president in 2010, and of course, he has also been the IMS representative to Asia Pacific Menopause Federation. He's been on the editorial board of Pediatric Oncology Journal and Journal of Midlife Health. And I have seen sir mentoring so many youngsters to come up in their own fields and train them. Sir, we are very much honored to have you here with us today and for encouraging us by being with us. So we await your pearls of wisdom and guidance from your side for today's webinar and for all of us in our lives.
Thank you, Surekha, for kind words. I know that you are quite enthusiastic and energetic as far as academic work is concerned. And so I couldn't say no when you called me for this. Dr. Rashmi is also known for a very long standing academic work. I'm glad to see Dr. Iralal is not there. Dr. Varsha is there. My friend Dr. Ritu is also here, and so many other people are also there. Deoli and Swani Obstetric and Gynec Society will help up so many from north to east. We are having one important thing today. The topic which you have chosen is quite interesting because we have become a diabetic capital of diabetic hub of world so much, and people are not still aware about it. That is what we want to have. We know that what are the complications to mother, what are the complications to newborn, and even long-standing complications later on. In my mind, we are going to discuss so many things because there are learned speakers, learned audience, and there are things also that the question answer will also be there. So we are going to take out everything good about it. According to me, there are 4 things which are required for this. One is awareness. Whenever people are not ready to say that diabetes can occur to them, they can occur to their older father, mother, but they do not know that it can occur during pregnancy and younger age also. Accepting. Once when you feel diagnosed and you tell them that you are likely to have blood sugar is high, so you have to be careful. They will not accept it. They will say no. So they will not like to tell other people also. So family awareness is also not there. Adjustment. Once you diagnose it, you have to do your lifestyle adjustment. You have to do your family things also, and your eating and other habits also to be changed. So that is also important. And last is avoiding complications. That is important part. That is can be done with prevention. That can be done with drugs, and that can be taken the expert advice. I'm sure today's webinar will be a nice one, and it will give a lot of information. When newer things whatever come out. When we were studying and we were thinking, we were only talking about insulin as far as diabetic mother was concerned. Now oral diabetic has come in a long way. We are going to discuss that topic also there. So at the end of this seminar, I'm sure that you are going to come out with lots of information. Congratulations to Surekha and wishing all the best for whatever she is contesting for. Thank you very much.
Yes. Thank you very much, sir. And we are really encouraged by your words. And we hope that all the esteemed faculty who have joined today will be imparting the knowledge, and so that we can transform this knowledge and bring it into practice. Thank you very much, sir. We will now invite our guest of honor, Dr. Varsha Baste ma'am. She's a very, very popular person amongst all the fraternity of obstetrics and gynecology. A practicing gynecologist from Nasik since 30 years. And she's a director of Pushpa Fertility Center. She's the CEO and founder of the Celgen Anti-Aging Center, first adult stem cell therapy center in Western India, first ICSI baby, PGD baby in North Maharashtra, past president of the OBGY Society of Nasik, chairperson of FOXY, International Academic Exchange Committee of FOXY, and she received the prestigious Dr. Anandibai Joshi Award. Above all, she's a great human being. We love her so much. She's so popular in her fraternity because the way she guides us, she conducts the programs, and she encourages, all of us to be together in her events. So that is how she is popular, and that's why we love you, Dr. Varsha ma'am, so much, and we await your guidance for this event.
Thank you, Dr. Surekha. I can see many faces which are my friends, and of course, Foxians, we know each other very well. And Dr. Atul Munshi sir, you are the Shahenshah for this webinar, because your guidance is very, very important. Thank you, Surekha. Thank you, Dr. Kahar and Dr. Anupam Gupta, Kiran Mai and Hyderabad Society. So many societies have associated for this important, very, very important webinar, because we need it in day-to-day practice for gynae also, for obstetric also. Hyperglycemia in pregnancy is very, very, very important. In and out, we come across such patients because, as Dr. Atul Munshi already has said, we are the capital of diabetes, unfortunately notorious, but it is the fact. And Surekha, your academic excellence, what should I say? Now you told me I am very popular, but I think you are also the same personality. Now I am going to be called a Jingalala girl, and you are a Jingle. So this is like the Foxy. When you come into the Foxy or in any this thing, the friendship bonds is very important. The fellowships are very, very important, and that are for lifelong. So Foxy gives you too much, tremendous everything, support and all advices, and we know how to help each other and how to take the academic excellence guidance or to update our knowledge. So I thank you for inviting me to be part of this important, very, very important topic, hyperglycemia of pregnancy. You have chosen it very well, and your academic excellence, accuracy, and the articulate knowledge, and the talk, the way you present all the subjects, it's very, very commendable, and I really respect your obstetric knowledge and whatnot. Thank you so much for inviting me. Over to you.
Thank you. Thank you, Dr. Varsha, for all the affection you shower on all of us, and really, bringing us together in all your events. So thank you so much. And over to you, Dr. Rashmi, for the academic sessions. Dr. Rashmi, you're there? I think some problem with her network may be there. So we go ahead with the academic session. And the first session is on screening protocols in hyperglycemia in pregnancy. For that, we have the speaker for today, Dr. Kiran Mai Devinani, and we have our expert, Dr. Ritu Joshi, chairpersons, Dr. Anupam Gupta sir, Dr. Shailaja Akula, and Dr. Nigat Pratos. I would like to introduce our expert, Dr. Ritu Joshi, to you again. Again, a very dear friend of mine, Dr. Ritu Joshi. We have been associated since long in the workshops which we used to do for reducing maternal mortality, the maternal death audit, and the maternal near-miss review workshops, which we have done in collaboration with Dr. Ritu Joshi in Rajasthan, which we had done started since 2010. And that is where Dr. Ritu and myself have been associated. And since then, we have been working and collaborating together in many academic events. Dr. Ritu is senior consultant at Forces Escorts and Surya Hospital, Jaipur, vice president of FOXI in 2014, chairperson of Family Welfare Committee in 9 to 12, faculty in various national and international conferences, and she has organized lots of events and conferences and contributed academically in chapters, in journals.
Rekha, don't waste time on this.
Right.
Let us go ahead.
But I would just like to say, Dr. Ritu, that I really value the association we have had in saving maternal lives. Over to, and I would also like to introduce our chairperson, Dr. Anupam Gupta sir, who is the past vice president. Can you take to the next slide, please? Anupam Gupta sir is the vice president of FOXI in 2015, chairperson of the IAEC committee. Dr. Varsha Baste sir is from IAEC committee from 2010 to 12, joint secretary FOXI in 2008. And we all know Anupam Gupta sir since 2008. He has been, we have seen him with Dr. Narendra Malhotra sir, and he's been the president of Agra OBGY Society, chairman of the Agra chapter of IFUMB, and executive committee member also, director of the Akanksha Test Tube Baby Center. Welcome, sir. We are really honored that you are here with us today. And we would also like to welcome our next chairperson, Dr. Shailaja, who is Yes. Rashmi, please go ahead.
Shailaja Madam has worked as FOXI secretary, hosted conference for Telangana and Andhra Pradesh. In 2010, she has worked as IMA secretary and got Best Secretary Award at Bengaluru. And since 2000, she's practicing gynecologist at Karimnagar. So we welcome you, madam, to the first session. Our next chairperson is Dr. Nigat Pirdos. Madam is consultant OBGY at Srinagar, and she is secretary of Srinagar OBGY Society. Her special areas of interest are high-risk pregnancy and emergency obstetrics. She is professor and former HOD GMC SGR OBGY. We are really honored to welcome you, ma'am. So for this first session, we would like to hand over to our respected chairpersons.
Yes, Anupam sir, can you please go ahead?
Good evening, everyone. It's a pleasure being here, meeting all my old friends, Dr. Varsha, Dr. Nigat, and Dr. Shahnaz. It was during my vice presidentship, we did a North Zone Yuva FOXI at Srinagar, and it was a pleasure having everyone there. So let's come into the speaker of today, Dr. Kiranmai, another very old friend of ours. She is the coordinator of the FOXI Dhira initiative, and she's the vice president and secretary of the Obstetric Gynec Society of Hyderabad. She is a scientific convener of the AICOG 2011 in Hyderabad, which was a wonderful conference. We all remember that. And she is also chairperson of the Adolescent Health Committee of Obstetric Society of Hyderabad. She is the postgraduate teacher and examiner. She's also a recipient of Amira Yuva FOXI Innovator in 2013.
Anupam sir, I think. Thank you, sir.
Yeah. Right. So let's have Dr. Kiranmai and let's hear what she's about.
Thank you, sir.
First of all, my regards to Atul Munshi sir, our guest of honor, Dr. Hiralal Konar sir, and Dr. Varsha ma'am, dear Varsha madam. And so thanks to Dr. Surekha madam and Rashmi for organizing this.
Somehow the network failure is affecting everybody today. Kiran, we couldn't hear you for half a minute. Yeah, please go ahead.
Is it okay now?
Yeah, it's okay.
So my regards to the guests of honor and my chairpersons, Dr. Anupam sir, Dr. Akula Shailaja madam and Nigat madam. I think Jammu Kashmir joined us today with Telangana. So happy. So without further delay, I would go ahead with my presentation, madam.
Yeah, I would also like to, meanwhile, when she's doing it, I would like to thank Dr. Anupam ji. Anupam ji has received the Best Committee Award of International Academic Actions Committee from Agra. So kudos to you, sir.
Thank you.
So respects and regards to all the mentors and seniors here, and it's a pleasure and privilege to be part of this, 25th ISOPA Vidarbha campaign that is going on, academics. So the topic given to me today is screening in hyperglycemia of pregnancy. So I would just be very specific and answer few questions on how to screen, whom to screen, and when to screen. So this is my passionate area about violence against women. So I request everyone, we can be their voice of our women. So the background is, we know that it occurs when the women's beta cell function is not able to overcome the antagonism created by the anti-insulin hormones of pregnancy and increased fuel consumption required to provide for the growing feto-maternal unit. So it presents mostly if it is GDM with recognition or onset during pregnancy. So the terminology of hyperglycemia in pregnancy, that is what we are saying now, HIP. So it includes both diabetes in pregnancy as well as gestational diabetes. Diabetes in pregnancy, either you diagnose before the start of pregnancy or you diagnose in the first time during pregnancy. Again, it can be type 1 and type 2, both of them. So HIP is a diabetes in pregnancy with a GDM. So the global prevalence, the recent studies and research shows it's around 16.2%. But for us in Southeast Asia region of WHO, we have a very high prevalence of 24.2%. And most of these cases occur in countries like us, that is low and middle income countries with low access to healthcare facility. And then in India, it ranges from 6 to 9% in rural areas and 12 to 21% in urban areas. And the rate at which it is diagnosed is 16.3 when under 16 weeks, 22% in 17 to 23 weeks, and after 23 weeks, the rate of diagnosis is 61.3%. So why we should are so worried about this? There is a trilogy of risks. That is, one is mother is at high risk for the future development of type 2 diabetes, and then metabolic problems including type 2 diabetes in the offspring due to the intrauterine programming, and then increased perinatal morbidity and mortality. These are the three issues that we have. Then health risks when we come to the mother, fetus, newborn, and also the this newborn when it becomes child and adult. That is, for the mother, birth trauma, increased operative delivery, preeclampsia, type 2 diabetes, and metabolic syndrome. Whereas for the fetus, it is the hyperinsulinemia inside the fetus, which does a lot of things, including macrosomia, then insulin resistance, etc. Then the cardiomyopathy in the fetus, which can cause sudden IUDs and stillbirths, LGA, macrosomia, and birth trauma. Then newborn faces RDS, hypoglycemia, hypocalcemia, hypomagnesemia, cardiomyopathy, again hyperviscosity, polycythemia, and hyperbilirubinemia. Then this child newborn can go on to become an obese adult and type 2 diabetic and also have a metabolic syndrome. So pregnancy GTT, when we study how it affects on offspring and the maternal glucose, it's a spectrum. It's not that this cutoff below that is healthy and above that cutoff it is going to be diabetic. When it is less than 100, the abnormal GTT is less, and diabetes at age of 15 to 19 also is less. This is from a paper on diabetes. And then when it is more than 200, you can see that diabetes at age 15 to 19 becomes as high as 28%. So that is the importance of the maternal glycemic control. Then evidence which shows that our interventions, which will be described in the course of this webinar, I'm sure that they improve the pregnancy outcome. There are two important studies. One is this Australian carbohydrate intolerance study in pregnant women, where it has shown 4% incidence of serious perinatal complications like death, shoulder dystocia, nerve palsy, and fracture in the non-intervention group, compared to 1% in the intervention group. Then the most important study on which the IADPSG and then the DIPSI guidelines have come is the HAPO study, that is hyperglycemia and adverse pregnancy outcome study, which has proved beyond doubt that your control is going to matter and that hyperglycemia is having a lot of dangerous effects and in the fetus neonate. This is a prospective blinded international study, multi-centered, 10 years, involving 25,000 pregnant women enrolled, which established the linear positive association between maternal glycemia and adverse pregnancy outcomes. That is the HAPO study. So the results are, you can see that there are three things which they had very clearly compared. One is birth weight more than 90th percentile odds with odds ratio, and primary cesarean rates, and the CORD-C peptide about 90th percentile. So it very clearly correlated with the fasting plasma glucose on 1 hour plasma glucose and 2 hour plasma glucose. So as the plasma glucose has increased, all the three things have increased definitely. So now that proves the benefit of interventions. Now whether to go for universal, beyond doubt, there is no doubt that you have to intervene these pregnancies. Then coming to universal or selective screening, current ADA guidelines, that is American Diabetes Association, recommends selective screening of high-risk women, whereas ACOG advise universal screening. NICE recommends screening all women of South Asian ethnicity. But in US too, many do the universal screening. Now, when we come to the selective screening, it does happen in spite of telling so many times in DIPSI and all our webinars, there might not be universal screening and many would be still doing the selective screening. So when we see the risk factors and the odds ratio, you can see here prior GDM is odds ratio is 23. Then Southeast Asia, the ethnicity itself is 7.6. And if you have a sibling with diabetes, it is 7.1. So now, what are the problems with selective screening? The significant proportion of GDM cases would be missed. And if you use broader criteria, only 9% of cases would be missed out, but 80 to 90% of subjects would need to be screened. But remember, in India, there is no place for selective screening because we are the diabetes capital of India, capital of the world, and we have a very high insulin resistance. And that is the reason we go for universal screening. Then what are the common dilemmas is we have answered to screen or not, yes. Then universal or selective, we have answered almost. With the further evidence comes that we have to do universal screening. Now comes the remaining questions. What is the time of screening? When to go for repeat screening and the method of screening? Here comes lot of dilemmas, so many tests, so many criteria, so many guidelines are there. I would try to resolve and clarify as many questions as possible. So what is the confusion? You know, there is no uniform GTT protocol. We have different challenges. Some say 50, 75, 100, then some say one step or two step. We have different thresholds for these same challenges, Carpenter-Couston, NDDG, etc. And then we have different durations, 2 hours and 3 hours, and different media, capillary blood, venous plasma, etc. And we have umpteen guidelines right from international ADA, ACOG, NICE, Australasia, FIGO. Then I have highlighted in red what are most important to us. Globally, WHO is the most accepted. Then comes the internationally, very wonderful IADPSG guidelines. Then the thing which is suggested by our government and DIPSI, the phenomenal work done by DIPSI, our own Seshaya sir and Hema Divakar madam and the whole lot of team at Foxy. So we'll just go through. Then this is this table which shows all the guidelines in one slide. Here you can see the IADPSG, 75 grams, 2 hour OGTT. And it has fasting 1 hour and 2 hours, 92, 180 and 153. Most of them stick to this. Then DIPSI, no fasting, no 1 hour. It is only 2 hour postprandial, that is with the 75 grams, 2 hours. Then we no longer discuss this Carpenter-Couston or the older ADA. Then again, new ADA 2015 or ACOG guidelines have come, which are 75 grams, 2 or more or less, like IADPSG 92, 180 and 153. And the WHO, which has given these values, So two-step procedure is, step 1 is we give a 50 grams glucose challenge test without regard to last meal or time of day. If it is around 130 to 140 milligrams of deciliter, then you are concerned. Then you go for the step 2, that is 100 grams OGTT, and measure 0, 1, 2 or 1, 2 and 3 hours. Then what are the fallacies? So a value of 130 milligrams increases the yield, but at the expense of 20 to 25% false positive. And mostly 25%, I think it would be more in Indian scenario, do not report for the second step. So some people still do this 50 grams, it is no longer advised and no longer feasible. Then comes the 3 hours GTT. We know all the hassles with that, 8 to 14 hours fasting. It should be done with patient sitting. And then stress-induced norepinephrine, then the vomiting in the first trimester, and 3 samples or 4 samples which are really painful. Then these are the 3 criteria: Sullivan, Mahan, NDDG, Carpenter-Couston. We have read in our MDs and MS, and I've written all the theory and practical questions, etc. Then comes the WHO 2 hours 75 grams OGTT. So what does the WHO say? So it categorizes when the value is more than 200 milligrams. In pregnancy, it is diabetes. Outside pregnancy also, it is diabetes. Whereas if it falls between 140 to 199, in pregnancy, it is GDM. Outside pregnancy is impaired glucose tolerance. whereas in 2 hours, 120 to 139, it is glucose intolerance, gestational glucose intolerance. So you can see that in pregnancy, even above 120 is going to cause some intolerance and some effects in the fetus and neonate. So why 140? Because when it is more than 140, the serum C-peptide is more than 90th percentile, and the type 2 diabetes risk increased to 30% in the children born to a mother who has a 2-hour plasma glucose of 140. So that is the importance for the cutoff of 130. And what is this 120 to 139? Now it is GGI in WHO as well as even in DIPSI also it is called as glucose intolerance related to pregnancy. Again, it is still associated with a graded increase in adverse maternal and fetal outcomes. So we should be very careful in this 120 to 139 also. And the macrosomia increases from 120 milligrams per deciliter onwards. And the risk also of type 2 diabetes is not less, it is around 19%. So IADPSG, this is the International Association of Diabetes in Pregnancy Study Group, the international counterpart of our Indian study group. It proposes 2 phases. So first prenatal visit, either fasting plasma glucose, glycosylated hemoglobin or random plasma glucose in universally all women. So if it is not diagnostic and the values are normal, go for a 2 hours, 75 grams OGTT at 24 to 28 weeks. This is what IADPSG advises. And these were endorsed by WHO, ADA, except NIH. And then ADA has offered either you can go for 1 step or the 2-step procedure. So what are the strengths of this IADPSG? It is outcome-based criteria, because HAPO, based on HAPO study, it has formulated its criteria, and we can reduce the fetal and maternal complications. Simplicity, it is simple enough, more patient-friendly, accurate, and close to international consensus. So what are the weaknesses? Again, as I have told, attending the visit in the fasting state for our pregnant women is impractical in many settings. Dropout rate is high. Asians, we have high insulin resistance, and so our 2-hour PG is more higher compared to Caucasians and more specific rather than our fasting plasma glucose. So FPG is not an appropriate option is what is felt in the Indian scenario. So here come the DIPSI guidelines. So what do we have in India? High patient load, CHCs, PHCs, rural settings, reluctance to give many blood samples, need for fasting, 2 visits, all these things. And also the scientific basis that about 2-hour blood plasma sugar, how important it is. They have identified a single step to do away with the fasting state. So what is the method? We give it has modified the WHO 75 grams as follows. So we don't ask if she's fasting or not. We give her 75 grams in 300 ml of water over 5 minutes and take a venous blood sample at 2 hours and see how the values are. So if it is equal to or more than 140 milligrams per deciliter, the woman is GDM. So we do it first trimester and again repeat it 24 to 28 weeks. Then when to screen all the pregnant women first visit and then second time after 24 weeks. So NHM Government of India guidelines, Ministry of Health and Family Welfare, they suggest they have accepted DIPSI for the screening protocol. So this is the algorithmic chart which I was mentioning. So I'll not repeat it. So this is in our guidelines module. So that is 300 ml, 5 minutes, and we should use a plasma standardized glucometer, not automated or semi-automated assays, which will take later, to give the value and asking the woman to, come tomorrow or day after for the values. And if there is a vomiting within 30 minutes, we have to repeat the test next day. If it occurs after 30 minutes, the test continues. And the instrument is, as I have told, plasma calibrated glucometer instead of a semi-auto analyzer or auto analyzer because of the delay in getting the results. And all health facilities should have this in the clinic itself. And calibration should be recommended after 20 measurements using calibration test strips provided with the glucometers. And the annexures 8 and 9 very clearly give further details regarding this. So apart from DIPSI, WHO in 2013, while recommending IADPSG, also recommends the single-step procedure of DIPSI for diagnosing GDM. So this paper reviews the whole gamut of guidelines and has found DIPSI to be equally useful. So why do we screen at 24 to 28 weeks again? Because what happens if we screen at 24 to 28 weeks and not in the first trimester? So the importance of screening as soon as the patient comes is that insulin is detectable in the fetal pancreas as early as 9 weeks after conception, and the B cell mass and the insulin secretion in the fetus occurs by the 16th week of gestation in response to the maternal hyperglycemia. So if you don't detect this, the baby is already going to be affected, because there is a risk of accelerated fetal growth even when the mother enjoys good metabolic control in later in pregnancy. So that is the logic and basis for the first trimester screening. Coming to the glycosylated hemoglobin, ADA does say it. So, but there are disadvantages: costly, limited availability, and certified methods. Standardization is not satisfactory with us. Presence of hemoglobinopathies, variation in red cell lifespan, all of these may invalidate the results. So this has been our experience at hospital, the Osmania Medical College, where we had worked. This was a paper presented in the second National DeepSea 2007 by our professor, Dr. Pratibha. So 1,000 cases, which they have done universal screening with WHO method. And then the prevalence was 1.93%. Our patient category belongs to low socioeconomic status. And in 10 to 12 years now, we have seen a spurt of increase in the gestational diabetes. And screening only high risk misses 53%. That was the conclusion. So to summarize, screen universally, first trimester screen, then go for 24 to 28 definitely, and depending on this thing, you may even repeat the screen. Don't go for GCT, either WHO or IADPSG, but because of these cumbersome and multiple samples, you can very safely go for the DeepSea single step for Indian setting, both for screening and diagnosis. And remember that intrauterine programming of the fetus in the mother with GDM leads to obesity, lifestyle disorders, and type 2, 30% in the offspring, affecting the future generations. And preventive measures should start from intrauterine period and continue throughout life from early childhood. So with this, I end my presentation with a request that I'm also, I'm also desirous of working in FOXY. And I'm going as chairperson for the No to Violence Against Committee. And I request all the blessings of the elders and seniors and my colleagues here.
Thank you, Dr. Kiranmai. That was, yeah, please conclude.
Yes, ma'am. Thank you. That's the, I request.
Thank you very much. And it was really nice to hear all the guidelines directly from the professor's mouth. And over to you, chairpersons, and then we'll have Dr. Ritu's summary as the expert. So the chairpersons, Dr. Nigat, please. Madam, please unmute yourself.
Can you hear me?
Yes.
Good evening, everybody, and a very nice evening. The presentation, as far as the presentation, it was very crisp and very interesting. So I really congratulate Madam for giving such a crisp and very, very up to the mark. I mean, she's a professor. I don't have to say those words for her, but it's really, it just went into the head. It was a revision for us, but it went into the head very easily and a very simple method. So it was very nice of her.
Yeah. Thank you, Dr. Nigat. We do have Dr. Shailaja here. Dr. Anupam, sir.
Yeah, I agree with Dr. Nigat. Dr. Kiranmai, I've heard her so many times before also. She is always to the point, and she's really given us a very crisp and to the point presentation. Thank you, Dr. Kiranmai, and wishing you all the very best for coming up in FOXY. We need young leaders like you to come up and spread, especially your Dhira program. All the best to you. Thank you.
Yes.
Thank you, Dr. Anupam. Is Dr. Shailaja there? I can't see her. Dr. Ritu, please conclude and the whole talk and hear your expert opinion too.
See, all of us are already aware that there's an explosion of diabetes in our country. And as far as pregnancy is concerned, we earlier used to diagnose diabetes very late. Only when we used to clinically find that there was polyhydramnios, so there was, some sort of congenital anomaly, and we used to really miss on diabetes during pregnancy. But now I'm really happy with this DeepSea test coming up, and FOXY really supporting this DeepSea test. And we can diagnose diabetes in pregnancy very much in time to keep it under control and to make the patient's journey throughout the 9 months very safe. So, and I also like the way Dr. Kiranmai did tell us that, in case if the, early part of pregnancy, nausea, vomiting is very high. Earlier, I used to avoid doing that 75 grams of glucose because it's very difficult to gulp that, 1 glass of glucose. But, of course, this half an hour thing also has now come up that if she vomits after half an hour, continue with the test. But if she vomits prior to that, repeat it again. That's something, which used to happen with a lot of my patients. And, we used to avoid doing it till 12 weeks. And then after that, she was under control, then repeat the test and all. But I think, we really used to miss out still a few patients. So I think we really need to stick to DIPSI and continue the way to do the glucose test with us, glucose challenge test, and to keep it under control. Thank you very much.
Definitely. Yes, that is our pehla kadam, our first step, I think, to do the uniform screening and not miss out doing the screening in the first trimester, and stick to DIPSI. We used to have a lot of discussions about doing the 2 hour, doing the 2-step, and then the 1-step, and so many things. And finally, now people are agreeing, yes, DIPSI is the one we should keep uniformly. We repeat in the 2nd trimester and in the 3rd trimester also. In our institute, we do in the 3rd trimester. Sometimes we miss cases, and even at 24 weeks, so we do again repeat in that 32. So that's our institute. But however, the government of India is saying 1st trimester and 24
weeks. Yeah, 24.
Yeah, so let's stick to that. Dr. Kiranmai has given a really nice, wonderful message for all of us. And we hope that everybody takes this pehla kadam and first step uniformly for all our mothers. So over to you, Dr. Ashmi.
Yes, let us move towards session 2 of this scientific program, and the speaker is respected Dr. Mitra Saxena Madam. The expert for this session is Dr. Ritu Joshi Madam, and the respected chairpersons are Dr. Aruna Suman Madam, Dr. Pradnya Chende, and Dr. Amita Gupta. I would like to introduce our respected chairpersons to the house. Dr. Aruna Suman Madam is Professor OBGY and Vice Principal, Government Medical College, Jagtial, Telangana, and she is Vice President, OGSH, and Joint Secretary, Fox. Welcome, Madam.
Thank you.
Pradnya Chende is Associate Professor, Department of Obstetrics and Gynae, LTMM CNJ, Secretary and Manager, Jogi, MUHS recognized postgraduate and undergraduate teacher, and a member of Youth Council of Marks. Welcome, Dr. Pradnya.
Thank you.
And Dr. Amita Gupta, Madam is Professor OBGY, Medical College, Jammu. She is Officer in Charge, HRRC under ICMR, and undergraduate and postgraduate examiner in various universities. At present, Madam is Secretary of Jammu OBGY Society. We welcome you, Madam. I would like to hand over the session to our respected chairpersons.
Thank you, ma'am. Am I audible?
Yes, ma'am. Yes, Amita, ma'am. Please go ahead.
Good evening, everyone. Thank you so much for this opportunity, Dr. Surekha Taide. You always conduct webinars with a good academic excellence, and it's my privilege to be with you all today. Dr. Amita ma'am, would you like to introduce Mitra ma'am, who is a very good friend of mine, an all-rounder, a very intelligent and dynamic person. Ma'am, Amita ma'am,
yes,
do you want to introduce?
For giving me this opportunity to introduce Dr. Mitra Saxena ma'am, and she is chairperson, Practical Obstetrics Committee, FOXY, and she is a senior consultant OBGY in private practice in Rewari, Haryana, and past president and now patron of Rewari Obstetrics Gynae Society. And
Dr. Amita.
Yes. Yes.
आगे चले क्या? Thank you so much.
Okay, ma'am. I welcome you, ma'am.
Thank you.
Mitra ma'am, it's
very thankful.
Really
I would just like to say a few words about the Jammu Society and the Srinagar Society. So, lovingly joined and affectionate I think Dr. Amita Gupta and Dr. Nigat, and yesterday we had Dr. Jyoti Haq also. And so all the two major societies of Kashmir has been with us. So thank you very much. We go ahead with Dr. Mitra, talk on use of metformin in GDM.
So a very good evening to everybody. Am I visible and am I audible?
Yes,
definitely. Yes.
Okay. So
You are
that's
audible and visible.
first slide. Why is it not moving? Okay. So a very good evening to all the esteemed seniors, most respected Dr. Atul Munshi, my dear friends, Dr. Varsha, Dr. Anupam, Dr. Ritu, who have been here chairing the sessions, and the guests of honor, chief guests, and of course, Dr. Kiran May, the chairpersons of the first session, and chairpersons from my session, dear Dr. Aruna, Dr. Pratnya, Dr. Amita. And let me inform the house that I have been Dr. Ritu Joshi's friend since childhood. So that's a lovely point for me to be with my friend in this webinar by you, Dr. Surekha. So the topic that has been given to me, or kind of even chosen by me, is use of metformin in gestational diabetes mellitus. So Dr. Kiran Mai has taken us very nicely through the dilemmas of, should we do universal screening? Yes, we should do this universal screening. What is the best method? We already know. It's the DIPSI. And then now we all know, I will be briefly taking you through GDM and what are the good options now we have. So GDM, as we all know, is carbohydrate intolerance, resulting in hyperglycemia of variable severity with onset of first recognition during pregnancy. To simplify things is the order of the day. So to make it very easy and finish all the confusions about pre-gestational diabetes, gestational diabetes, diabetes mellitus, this, that, and the other, the nomenclature now which is being recommended and used all over is FIGO recommends to mention it as hyperglycemia in pregnancy. Dr. Kiran has very nicely told us all the problems that can happen to the baby, to the mother during this pregnancy and also beyond. So it's quite important to recognize this identity and take it from there. So what we have to understand is that normally pregnancy is a diabetogenic state, meaning to say that there is a natural insulin resistance to work in the favor of the transmission of all the products towards the fetus. So basically, we all know that in pregnancy, in the second half, all the hormones, they are all going to cause insulin resistance so that there is preferential collection of glucose on the maternal side, which can be transferred to the fetus. But unfortunately, wherever a woman actually also develops insulin resistance, she manifests as diabetes. So basically, this was a very physiological change, which was orchestrated by nature so that you could have more glucose transported across the placenta to ensure normal growth of the baby. But in gestational diabetes mellitus, the mother's insulin resistance surpasses so that there is metabolic imbalance. And what we find is adverse perinatal outcomes, increased size of the babies, macrosmias, inductions, cesarean sections, and so on and so forth. So friends, what we have to understand is that what we used to diagnose in hindsight, whenever there was an unexplained IUD or a big baby, or we are getting stuck in, shoulder dystocias, then it was a flashback and patient would be investigated for ruling out gestational diabetes. But now it has been, we have to understand that this entity can no longer be ignored because of the consequences it has on the baby and the mother in pregnancy and even beyond, because this has got effect in the future generation, that there will be, the baby will be having more problems if it's a macrosomic baby. So we cannot ignore gestational diabetes any longer. It has to be investigated, and the hyperglycemia in pregnancy needs to be addressed at the earliest, knowing all the problems that can happen. So this is a risk factor for developing type 2 diabetes in later life. This is a risk for all the complications during this pregnancy in the form of bigger weight, hypoglycemia, jaundice, birth trauma, stillbirth, and in the mother, and even in the baby, there can be metabolic syndromes, obesity, and diabetes in the newborn later. So we have to understand that GDM needs to be very, very carefully kept in the back of our mind. Even if a patient at the first screening does not show any symptom or sign of deranged blood glucose levels, it doesn't mean that we should not go back and investigate again in the second trimester or in the 24 to 28 weeks. We all know that gestational diabetes mellitus, the mother is at the risk of having type 2 diabetes, gestational hypertension, preeclampsia, all the complications because of polyhydramnios, prolonged labor, uterine atony, PPH, infection, and anything and everything. Similarly, also in the fetus, we know all these complications are on the rise when this entity is, goes undetected. And also we have to understand that gestational diabetes mellitus is a very important contributor to the burden of non-communicable diseases. So already Dr. Kiran has taken us through the protocols for investigating, and I'm only going to reiterate that at least 2 times this effort should be done. One is at the initial booking in the first trimester, and second should be done at 24 to 28 weeks. That is the time when the diabetogenic effect is at the peak. So the deranged glucose intolerance will be easily detected if we do the DIPSI 75 grams 2 hours testing of the blood sugar. So I'm not going to repeat all this because this has been said already. And this is the key slide. I mean, this is what we are following, that non-fasting, in a non-fasting state, give 75 grams of glucose. And after 2 hours, if the blood sugar is more than 140, this woman merits a complete checkup of 2 hours GGT. This is so that at least we should remember this is the minimum. This has, fulfills almost all the criteria. If we do one testing at the outset in the first trimester, or if we are fortunate and our patients can afford, and we do HbA1c, which tells us the status of 3 months before, that would be a very value addition to screening for GDM. Now, what is important to understand is once you've diagnosed GDM, what are we supposed to do? It is very well known by all the studies that if you do not diagnose it and you miss it, you have all the complications. But once you diagnose it, then you have to address this problem, and the metabolic derangement has to be taken care of. Now, what is it's very simple basically. I am in a webinar, I'll call you later. So these are the 3 mainstay, or I should say 3 pillars to manage gestational diabetes mellitus. We are all aware that medical nutritional therapy and lifestyle modification, these 2 are, the cornerstones. But, you cannot jump straight to the pharmacotherapy or medical management of GDM, because you have to give a very good trial to good medical nutrition therapy and lifestyle modification. Having said that, we all know that you cannot wait, you cannot sit on it. You have to make a call, and if the patient's blood sugars are deranged, we have to consider the medical management of GDM. So we all know that insulin is basically the mainstay of treating diabetes mellitus. But in pregnancy, there is a lot of problem because, insulin needs to be explained. The use of insulin needs to be explained to the patient, more tight control, more frequent estimations of blood sugars and daily injections. Risk of hypoglycemia is very much there. So do we have a good alternative? Yes, friends, metformin is a very good alternative in managing gestational diabetes mellitus. A few years ago, we were always confused. In PCOS patients, we were giving metformin, and then once they would conceive, there was always a question at the back of mind: should we start it? Should we continue it? Should we stop it? What should we do? Now it's very, very clear that see, in this, it has been seen that if the subjects are taking metformin, the improvement in metabolic control is very much there. Rather, in insulin group, there are cases when there will be neonatal hypoglycemia or higher NICU admission rates, or even despite use of insulin, there could be higher birth weight and more maternal weight gain. Whereas with metformin, there was very much, acceptable. So basically, despite the fact that insulin is the ideal treatment for diabetes mellitus, we have a fantastic alternative in the form of metformin. So I will be taking you through this wonderful molecule, which is a positively charged biguanide. Now this, according to American Diabetes Association, in a normal patient who's not pregnant, this is definitely the first line of oral therapy according to the latest guidelines. So there are at least 120 million users all over the world already, and it's an insulin sensitizer. Now in pregnancy, it has been found that it, of course, it has a lot of GI symptoms: nausea, vomiting, giddiness, metallic taste, because of which this may be a challenge to start and manage patient on metformin. However, it is, I'm going to be discussing about the MIG trial, the metformin in hyperglycemia trial, which is a wonderful, reassuring trial. So also, there was immediate release metformin, which was causing a lot of gastrointestinal side effect. But now in the markets, the formulations is extended release. So it doesn't get released so fast, and it doesn't produce so many side effects, especially the nausea and the vomiting. So with the extended release metformin available, we have a good alternative. Of course, metformin does cross over from the placenta towards the baby side, but we do not have yet long-term studies in the babies about effect of metformin. So when metformin is very, very safe, and it has to be started in a low dose, in the night dose for the first week, and it has to be gently increased, of course, checking the KFT and the LFT, and it can be, increased to the required doses. Maximum, it should be taken in 2, say, divided doses. What is very important about metformin is how does it act. So as I said, this is a positively charged ion. It cannot cross the cell membrane just by the passive diffusion. It needs organic cation transporter, which is in the hepatocyte. And it is very intriguing to understand that this molecule, which has been there for over 4 to 5 decades, has suddenly, we've realized how varied its actions are. At cellular level, it will be important to realize that in the hepatocyte, what metformin does is it decreases the gluconeogenesis. So it actually, once it is in the cytosol, it acts on the mitochondria, and there it inhibits the respiratory. So the ratio of ATP and AMP is reversed. Instead of having high ATP, we have high AMP, and that is the key, metabolic reaction. So what it does is it decreases the lipogenesis, decreases the steatosis in the liver cell, and also decreases the gluconeogenesis, which is one of the reasons why there will be hyperglycemia. So the main action of metformin at the cellular level in hepatocytes is it causes delay, slows down the respiratory chain oxidation at the mitochondrial level, and that decreases the neoglucogenesis, and it also inhibits the glycogenolysis. So from all the sources where you can have increased glucose in the blood level is inhibited by this wonderful drug. So at the level of intestine, it decreases the absorption. At the level of liver, it decreases gluconeogenesis, glycogenolysis, and decreases the hyperglycemia. So at the level of skeletal muscle, it increases the insulin-mediated glucose uptake. Basically, it increases the sensitivity of the insulin, which is present peripherally. All in all, metformin decreases the hyperglycemia. So in addition to its effect on the hyperglycemia, this molecule also has anti-obesity effect. It has anti-hyperglycemic effect, as I told you. It is decreasing levels of glucose from all over. It has anti-lipidemic, anti-diabetic, hepatoprotective, cardioprotective. Basically, right now we are at the brink of, realizing how varied the effects of metformin are. In addition, it is also, it decreases the carcinogenesis. So it's a wonderful molecule which has been in use for many years, but now it has gained so much importance. Now, a word about, and the most important part is the big trial. This is a wonderful trial where 11 studies are there. And once one goes through this trial, one has sufficient confidence to begin using metformin for treating gestational diabetes mellitus in all our patients, because this is a very viable alternative to insulin. The primary outcome in all these trials was looking at the baby's outcome at the baby. What was the neonatal complications like ABGA score, any hyperbilirubinemia. All the primary outcome in these trials was with respect to the fetal outcome. And the secondary outcome was depending upon the response in the mother. So all these studies show that the effect, the use of metformin is very safe, and the control in the mother was very impressive, and very little complications in the mother. So also the effects on the baby were very, very reassuring. So having gone through these studies, one would, be quite confident in using. Now, this is a very important slide which summarizes, on one hand, metformin, and on the other hand, insulin. So the outcomes which were measured on the maternal side was maternal weight gain, hypertension, PIH, and any increase in cesarean section. And this was the neonatal outcomes which were compared. So it was found that metformin was very comparable to insulin, and in some cases, in fact, it even fared better than insulin. This is a class B drug, and it's very easy to use. Of course, if we cannot, load the patient with full dose of metformin. It has to be done very intelligently and taking a feedback from the patient. So friends, this MIG trial is very, very reassuring when we come to finding another, molecule to help us through and make sure that the glycemic control in a woman with gestational diabetes mellitus is taken care of without the, so many patients have a lot of mental block in using insulin. Now, not every patient is going to respond very nicely to metformin, and we may have to fall back on our endocrinologist friends or our own physicians and our own knowledge of use of insulin. So, and a patient who has very high fasting glucose level at diagnosis, or the gestational diabetes is detected very early, past history of GDM, older age, very high baseline. So wherever diabetes is very, very overt, very obvious, and we do not want to, because it's going to take time for metformin levels to build up, control the blood sugar. So wherever we have these conditions where patient is not responding, or she has frank gestational diabetes, 5 minutes, and high fasting glucose level, we may have to resort to insulin. Yet, the first time diagnosed patients with hyperglycemia, it would be prudent to give a fair trial of metformin in these patients. The take-home message from my side would be that every pregnant woman deserves to be screened for gestational diabetes mellitus, and if or whenever the GDM is confirmed or diagnosed, the mother has to be monitored, the baby has to be monitored, and antenatally, intrapartum, and also later. We cannot finish it off just with the delivery. Both the mother and the baby need to be investigated. The mother has to undergo GTT at least 12 weeks after the delivery, and also the baby's birth weight and anthropometric chart must be maintained in the, in the big trial also. There was a, one of the series has 2-year follow-up of the babies. And right now, we are at that time, we have to investigate and follow up these babies who are being treated, mothers who are being treated with metformin to correct GDM. So already we know that DIPSI is the ideal screening method. Confirm it with OGTT, monitor the weight gain and the hyperglycemia, add on metformin and or insulin if metformin is not sufficient on its own, monitor for side effects and long term of metformin on baby, not yet documented, but it is fairly safe drug. So this is a 50 years old, but gold kind of a medicine. And let us not forget that it is when as an obstetrician, we have to, when we are managing a woman, it's not by the book, but it's by the patient. We have to consider her IQ, her understanding her disease, and then getting back and follow it up. It's not enough to just prescribe. This is very important to follow and make sure that what we have set out for, we achieve that. And that is least maternal trauma and good obstetric outcome with respect to mother and baby. So these are my references. Thank you so much. It's always really helpful to.
Thank you, Dr. Mitra. 50 plus and gold. That is what is Dr. Mitra. And thank you for holding our my hand through all the academic activities which all of we are doing at ISUPARP and Deoli Sawangi, and wonderful with a lot of the research trials and evidences from your side. So over to you, Dr. Aruna.
Sorry, Surekha, I'm so sorry. I'm having a very bad throat. I'm not feeling well. And
thank you. You've really done an excellent and a lucid presentation. I think you have covered all the important points. Few things I would like to say is, you mentioned about the 2-step screening. So usually we screen the patients at the first visit, but sometimes it manifests after 28 weeks. And you also mentioned, highlighted medical nutritive therapy, lifestyle modification, and you suggested the use of extended release formulations. And overall, metformin, I think, has stood the test of time. And you have provided evidence in your talk. So it was a very elaborate and a very lucid presentation. I congratulate you. And I would also like to thank Dr. Surekha Taide and all the members who are contesting for the elections. I would like to give them my best wishes. Really thank you for inviting me to this
Thank you,
program.
Dr. Pradnya. That was really nice of you to join with us. And Dr. Pradnya is doing a great job with Jogi. And really, the Dr. Mitra's talk was all of the evidences which she has given
What
us.
I like is, yes, evidence-based management is the key nowadays. And Madam has provided evidence.
Yeah.
Absolutely.
Aruna, ma'am.
As usual, Mitra Saxena, madam, it was an excellent talk. You have given us a good insight on metformin, the role of metformin in GDM. You told us about this is the first drug of choice according to the American Association. Thank you. And the extended formulation really helps during pregnancy, which prevents hypoglycemia, and it doesn't cross the placenta, but still we need more studies. And the MIG trials you have told were really good. And I think we can use this drug without any fear now. Thank you so much for this knowledge.
Ramita ma'am.
Government of
Yes,
India.
my just one carry
Yes.
home message would be that yes, we can use metformin and with very safe drug, but the idea should be that we have to keep the fasting blood glucose around 95 and postprandial around about 120, and then if the need be, we can add insulin.
Yes.
And another oral hypoglycemic agent, that is sulfonylurea, which the studies have shown is again safe, do crosses placenta, but the overall effect on the baby are not much as compared to the insulin. Thank you.
So we have insulin, we have metformin. Government of India is saying that you can use metformin even before insulin. So that's important, I think, and especially in patients who have on our PCOS already on metformin, they conceive. So that is where I think these are the, I think Dr. Ritu will shed light on that as an expert.
Is any question allowed?
Yes, ma'am.
I'm really happy you spoke about this talk, the metformin today. Initially, we used to give, we were very happy when our patients on in PCOS continued into it. And, we used to be so scared that should we continue with metformin or should we not? And we used to stop metformin, and ultimately they used to land up as metabolic disorders, and diabetes was one of the very common ones which we spotted in them somewhere around 28, rather even early, somewhere around 24 weeks only. So to continue metformin is something very nice, and we also now should start gaining the confidence that they don't cause any congenital anomalies, they keep the sugars under control, and we have a first drug with us which is very which has more compliance for a patient. She wouldn't really like to go on and on taking the insulin. It's better to have this, and then in case if required, shift her onto insulin whenever required, as per the diabetes. So, I'm really happy that the PCOS patients can easily continue into metformin.
Yeah, Dr. Kiran, we want you to say something.
Claire, we are doing Can I ask one question, Dr. Mitra?
Yeah, Dr. Varsha Baste, ma'am, please go ahead.
See, excellent talk with the molecular level and whatnot. I'm really delighted to witness your knowledge and your updates, Dr. Mitra. It is said that the baby's weight reduces with the use of metformin. What's your take for that?
Please say again.
It is said
baby's weight
that
reduction.
at the full term, when we are using metformin alone, for control of GDM, and it is given for a longer time, the baby's weight reduces.
So that's our aim, I think.
That is our aim, that we do not have large for gestational age babies. Ideally, what we have to monitor the mother, it's with, if she is diabetic, we are not expecting any growth retardation. But what we are actually looking at is with hyperglycemia, there will be a bigger size baby. So if we manage to control the maternal hyperglycemia, that is, we are monitoring the mother's weight gain, and also, in fact, it will be it's a neonatal outcome we are looking at, that the baby's weight does not go higher. So we are trying to keep it down.
Babies, because I am doing more of infertility practice, and more morbid patients and high risk patients are there. At certain time point of the treatment, the baby's weight doesn't increase; it becomes static. It doesn't grow that at the full term. So that's our concern. So we have to take the patient for C-section and all. That's the only drawback.
Maybe I think in that case, there may be something else as well. It's not metformin which would be causing low birth weight.
It is because of the vasculopathy which is associated. Yeah. So diabetes is known,
more complicated patients we are already coming across. But this is my observation. So the baby's weight doesn't increase after a certain time. It doesn't increase. It doesn't have to come.
Take up a study, I think, to see the effect of birth weight.
It may be because of factors which she is having because she's a patient of infertility, and generally these patients have some problem. Rather, metformin children, they are supposed to be, studies have shown they are overweight, and that is why they compared metformin with insulin to see the babies are not affected. So
Okay,
here we have to look into other reasons.
Surekha ma'am, I wanted to only stress upon one thing. The Government of India guidelines have put metformin very clearly before going for insulin. The main reason is definitely its safety, proved beyond doubt. And the second thing is, it is so easy, effective, just like we have accepted DIPSI as screening protocol, they have put metformin before you go for a little more cumbersome insulin, because metformin can be administered and looked after by the ANMs, ASHAs or PHCs.
Actually, even in the non-pregnant ladies, because metformin is the first line of oral therapy for diabetes now, the world over.
I'm using it.
That is why metformin is
But
gaining.
Varsha ma'am, there is some controversy. The endocrinologists, they and even in PCOS patients, not all may be preferring metformin early on, but Government of India says very clearly you can use metformin.
And I'm using
thank you.
metformin because at molecular level it is used as anti-aging also, so it is very safe to use.
Thank you very much. I think that was a great discussion, and definitely the good take-home messages are there from this discussion. And we hope to throw more light on the management part in the panel, which is upcoming now. And thank you all the chairperson, the expert, and our speaker, Dr. Mitra Saxena. So thank you everybody, and we go ahead with our next session, Dr. Rashmi.
Let us move towards the scintillating and very interesting panel discussion. It's a case-based discussion on hyperglycemia in pregnancy. And the expert for this session is respected Dr. Mekha Krishnakumari, Madam. I would like to introduce Madam to the House. Madam is Senior Consultant, Medicover Hospital, Hyderabad. And at present, she is National Corresponding Editor of Jogi, National Coordinator Medha, Vice President TCOGS, and Member Clinical Research and Good Practice Committee, SAFOC. We welcome you, ma'am. I would like to introduce the moderator, Professor Surekha Taide, Madam. She's Professor and Unit in charge.
I've already been introduced here.
Okay,
Yeah,
I welcome you,
ahead.
And the panelists today are Dr. Archana Singh, Dr. Manasa Devasani. I would like to have the slides, please. Abhishek. Yes, Professor Archana Singh, Madam. She's Professor of Obstetrics and Gynecology, GMC Consultant at Yeshoda Hospital, Hyderabad. And at present, Madam is Secretary of Obstetrics and Gynecological Society of Hyderabad. Next slide, please. Dr. Manasa Devasani, Madam. Madam is Secretary at Karimnagar OBGY Society. We welcome you, ma'am. Madam is Senior Consultant Obstetrician and Gynecologist, Infertility Specialist and Laparoscopic Surgeon at Ankura Hospital, Khammam, Telangana. And Secretary of the same society.
Dr. Omana. She's Omana.
Yes, I would like to introduce Madam. Madam is working in Wayanad district for the last 35 years. She's the founder president, Wayanad OBGY Society, and president for the last 15 years. She's vice president elect, Kerala Federation of Obstetrics and Gynecology, and member of Practical Obstetrics Committee, FOXI. We welcome you, ma'am. Dr. Kiran Trivedi is Associate Professor, Department of OBGYN at Ranchi. Madam is Organizing Secretary of FOXI for Yuva Conference 2022 and Secretary at Ranchi Obstetrics and Gynec Society at present. She has been ex-Joint Secretary Ranchi OBGY and ex-Treasurer Ranchi OBGY Society. We welcome you, ma'am. Dr. Shainaz Stein, Madam is past professor and head of the Department of Gynae and Obs, GMC Srinagar. Madam is at present president of SOGS and has conducted first ever Yuva FOXI conference in state of Jammu and Kashmir 2015. She is an executive member of MP PCOS India and has been trained in sonology from Mulchan Khairatiram Hospital in 1994. We welcome you, ma'am.
So thank you, Dr. Rashmi. And we straight away go ahead to our panel. Is my slide visible?
It has started the screen sharing, but not yet.
Okay.
Yes, now it's visible.
Yeah. So thank you very much, Dr. Rashmi. And here we are to the scintillating panel. Let me at the outset give the disclaimer that Dr. Krishna Kumari Meka is the expert. And that's why I'm just going to put across the traces. And we also have esteemed panelists who are going to take us through all the answers. My job is to have the expert pitch in and provide all the opinion as far as the cases are concerned. So Dr. Krishna Kumari ma'am, who is my very dear friend, is here to be the expert in the panel. And somehow I think Dr. Omana has conveyed that she is not be able to join because of her mother's ill health. So I would like to ask Dr. Rashmi also to pitch in instead of Dr. Omana. And if Dr. Kiran is not there, then we will also have Dr. Mitra Saxena will be opining. So we have a lot of experts here. Dr. Kiran Mai is there also there. So all of you, I would like to join in the panel. So the panelists have already been introduced. This is my medical college, Jawaharlal Nehru Medical College, where I am serving as a professor. This is a very beautiful virtual lab, as you can see, the SIMOM, wherein we are training not only the doctors, but also the nurses and other peripheral workers. Let me present before you myself as your candidate for Clinical Research Committee of FOXI as a teacher, trainer, and a person who's having avid interest in research. So let us go to the first and foremost thing is what we have been talking about, the universal screening. Also, we say Pehla Kadam, or the first step. And let us all pledge that all pregnant women will be screened, and let us all work together and make this difference, the single step testing with 75 grams of glucose. And let us all give our mothers the chance of being detected and giving good outcome to them. With that, I come to the first case to Dr. Archana Singh. This is a patient who is a known PCOS with impaired glucose tolerance. She was on metformin 500 milligram once daily. She married recently. She presented in early pregnancy to you. At 10 weeks, you did her, what about, what is your opinion now? Are you going to do the 75-gram challenge test for her? Or would you like to do a fasting post-meal, HbA1c also? What about metformin? How to go about, Dr. Archana?
I will start from metformin itself. Dr. Mitra Saxena has already discussed, and I will say that it is better to continue metformin, but at the same time, we have to inform the patient that many times, in spite of taking metformin, she may need insulin also later. Second, we can counsel her that it is a category B drug, so it is safe as such, but long-term studies, sadly, we are not still having confirmed data about it. So it is safe and it is good for the patient because she is already having polycystic ovaries, maybe androgenic features also, and it will reduce the NICU admission as well as the preeclampsia in the patient. But healthy baby doesn't always mean healthy children. So long-term studies still are not confirmed, but still we can continue with metformin rather than stopping it. Then coming to fasting postprandial blood sugar or 75 gram, because if she had already had impaired glucose tolerance and she was already taking metformin for the with PCOS, then I will go directly for fasting postprandial blood sugar and glycosylated HB. Particularly if she is anemic, then I may go for different tests. But in case she is having normal hemoglobin, everything is fine, then these 3 tests will be more than enough.
Yeah, thank you. Dr. Krishna Kumari, what's your opinion?
Yeah, good evening, Dr. Surekha. Thank you very much for inviting me. I've been listening to the previous speakers. It was a wonderful sessions we had. So coming to the question and contest, like what Archana, I completely agree with what Archana has already put forth. But we have to remember that like we have, once upon a time, there was a time where in PCOS, every patient we used to give metformin. Then now we have become, again, that has been very much into, I mean, not every patient, but most patients randomly they were giving metformin. And now that has been more streamlined, and it's become more focused that we have to identify insulin resistance and give metformin to only those patients of PCOS who are having insulin resistance. So now once we look into that particular group where we are using metformin and this patient becomes pregnant, it's very important that we understand that like Archana said, the long-term studies or the long-lasting effects are not there. And I mean, the recorded versions are not there. The data are incomplete. So there have been random sporadic times when they said that if it is a male baby, it can cause lower sperm count. It can cause even subfertility and even testicular cancers in male babies. Whereas if it's a female baby, it's an advantage. It normalizes androgens, it normalizes insulin levels, it normalizes AMH levels. And again, the ovarian programming, which is happening in utero, is what is going to be which is going to be tackled by metformin. So there are many advantages of giving it also. So it's very difficult at this point of time to tell us. So what I would do is I would select my group of patients where definitely I think that there is going to be a high possibility of GDM coming up later, and then only start metformin. That is how I would put it.
Thank you. Yeah, I think it would be good to find out what is the glycemic control of this patient. Already she is a PCO, but she is on metformin. What is the glucose level? Let us find out that by doing the fasting and the PPBS. We do not want to give a 75-gram glucose challenge to this patient because she is already impaired glucose tolerance, and with pregnancy, we think that it will be worsened. So we do not want to give any glucose to her, but let's find out what is her glycemic level. And depending on that, we would like to, take the call whether you will want to continue the metformin, whether you would like to put her on insulin, whatever. I mean, her glycemic, the glucose levels will tell us. That is one thing. About HbA1c, it tells us about the previous 3 months control. So probably we can do for this patient HbA1c and find out what was a control. But she was IGT, so may or may not required. Okay, and so there are again a lot of dilemmas about HbA1c. We really do not do as far as our rural setups are concerned, but many corporate setups, they want to do. So again, the feasibility, the cost, and all these things are there. So one thing I think the take home can be that, yes, let's find out the glucose. What's her glycemic control? Give the do the fasting and the PPBS and decide whether you want to continue the metformin. If there's a need, you can continue safely. That is what the government of India is also suggesting. So with that, we go on to the next question. This is the same patient. Now, would you like to ask an early ultrasound for this patient, Dr. Manasa? Do you think it can predict PIH in this patient? What about prophylactic aspirin? Would you like to do arterial Doppler early on? And would you like to do some markers also so that we know whether this patient will land up into PIH? Dr. Manasa, please.
Good evening, seniors and friends. Such a lovely discussion I think going on. For this patient, I would like to start prophylactic aspirin depending on her urinary Doppler PA index. If the mean PA is more than 95th percentile, I will start at least 1 to 2 milligrams per kg body weight. But sometimes, as the incidence of preeclampsia is almost like 10 to 26% in case of GDM to preeclampsia, I want to start the aspirin even if the Doppler values are normal. Coming to the scan at 12 weeks, as diabetes, GDM or diabetes, pre-existing diabetes, as the more chance of NTDs, I would like to see any neural tube defects and everything in the NT scan, and even for chromosomal markers, I would like to see for the NT, nasal bone, and even ductus venosus flow regarding this. Coming to PLG. Coming to PLGF and other biomarkers, as in case of GDM, there is more prone for preeclampsia. I would like to see the ratio of soluble SFLT1, soluble FMS like tyrosine kinase 1 and PLGF ratio. Whenever the ratio is more, there is more chance of the GDM will be having later gestation for preeclampsia.
Yeah, but what about the availability, the cost of these?
Yes,
and I
actually,
think we do have a clinical score, which is the gestosis score, which is very nicely, I think, has come up. And I think that is what we can look into. What is her clinical profile? You can just go to the gestosis score and find out where she falls in, and that can actually predict very nicely. And of course, the Dopplers are important. I think the early scan is important, which can you know, guide us whether this patient really needs a prophylactic aspirin or not. What is your take, Dr. Krishna Kumari?
Yeah, I agree with you, Dr. Surekha. That's very true. I also like the gestosis score very much, and it's a very simple way of picking up those which are at high risk. I think that's very important that at every point of time we have to differentiate between those with high risk and those with low risk. And those with high risk, we definitely can start on aspirin. And you, like you rightly said, when we are doing an NT, we routinely are now adding the uterine artery Doppler to it. And so we do get
definitely. So we are doing more scans in the early phase nowadays in the first trimester than we used to do. You know, with the more and more update coming in, we do know that the first trimester scan is so very important, which can tell us about whether the patient is going to land in the hypertensive disorder or not. So Sabita, this is for you. Chances of malformation. Do you think that the ultrasound is going to pick up all the scans, all the malformations? What are the limitations do you see? Sabita is there? I didn't. Yeah, Sabita is there. Please go ahead, Dr. Sabita.
Yes, madam. Thank you, Surekha madam, for giving me this opportunity to be the part of this wonderful webinar. And yes, the chances of malformation will be more in case of hyperglycemia. Hyperglycemia is hereditary, and the most common malformations being the CNS and cardiovascular anomalies and even the kidney malformations. Coming to this CNS malformations, the neural tube defects were about more in case of gestational diabetes compared to the non-diabetic mothers, as high as 20 per 1,000 when compared to the non-diabetic, which will be very less. And the caudal regression syndromes, which are more specific for this gestational diabetic mothers, we routinely see. And the detection rates will be, when we do the early trimester scans, we can pick this anencephaly and all. Around 100% we can pick this anencephaly. But coming to this occult spina bifida and this type of anomalies may be missed when the baby is in active position, and we cannot pick that. And the rate of detection in these kind of anomalies like spina bifida, occulta may be missed. And we need to continue the screening and ultrasound. Whereas in case of GIT malformations like duodenal atresia, they may be detected at the later stages around 30-32 weeks also. So we should continue to educate the mothers that some of the anomalies may be detected in case of hyperglycemia. And regarding this cardiac anomalies, we prefer to do Doppler study also to detect some of the malformations of cardiovascular system.
Yeah, thank you very much. And I think that's very important message which has come up from this very good paper from 2012, that only 30% of the anomalies get detected. Some are evolving sort of anomalies, you know, later also the patient may be having. So we have to counsel the patient that some of the anomalies may be missed. These patients also are having high BMI, and that's why I think the counseling part is so very important, that all anomalies are not going to get detected. The incidence is quite high as compared to non-diabetic. Thorough examination of the spine may be difficult when the the baby is not in an appropriate position. Yes, so that's why I think counseling is so very important. Krishna Kumari, ma'am.
Yeah, I think one thing I would like to add to what you have already said is that every patient should go for a 2D echo, fetal echo at 24 or 22 weeks of gestation. I think that recommendation should be made a routine, so that this is quite often happening, that when we are hesitating, thinking that it is maybe taking it too far off, the people are landing up in problems. So
Yes,
I would
definitely.
say
And the target scan should be done from a good sonologist. I think that's very important, so that we don't miss upon anything, and we can do it early first, like 16 to 18 weeks. Even the first time with a scan, some of the anomalies are very nicely detected. So we can do at 18 weeks, we can repeat it at 20, 22 weeks. Nowadays, if the anomaly is there, we can terminate up to 24 weeks also. So let us plan, I think, so that we can do it at least 2 times for the targeted scans, so that we do not miss upon any anomalies. Dr. Omana is not there, so can Dr. Kiranmai take this question? This patient, he came to you with an HbA1c of 9.8 to want to terminate this pregnancy. Is Dr. Kiranmai there? Otherwise, Dr. Krishna Kumari, you can please. Krishna Kumari, ma'am, please. What do you think? 9.8.
No, if it is 9.8, yes, we know the risk is very high. It is almost touching 25%. The same thing I would be explaining to the patient, but definitely I would not say that go ahead with the termination. I would just explain the risk, counsel them, and I would leave it to them to and tell them all the methods. Now, like we have already rightly discussed, so we have so many ways of screening them. So definitely I would tell them to go ahead with all the possible screening. And if at all any anomaly comes up, yes, we would go ahead. For every 25%, there is also a 75%. That's what I would like to.
Yeah. So we can just tell them 1 in 10 if it is a chance that 9 fetuses will be normal. So, and we do have so many modalities of finding out if this patient is having problem or not. So that is how we can counsel them. And we can go ahead and, she may have been conceived after fertility treatment, and these patients do have a problem. So they conceive with difficulty. So I think we can give them the pros and cons, the statistics, and let them decide, and be helping and be supporting. That is what I think our management should be. Dr. Kiran is not there. So can Dr. Nigat take this, or Dr. Shehnaz? What about this patient, madam, you are on mute. So this is like a patient who was 9.8 HbA1c. Do you think we have some missed opportunities about the preconception counseling for this patient? Dr. Shehnaz?
Yes, good evening, everybody. Thank you very much for calling, for giving a chance to associate Srinagar in this webinar. The question is that what was the question like? I would like to hear again, please. Am I audible?
Yes, madam, you're audible. We have this patient who had an HbA1c of 9.8. So do you think that some missed opportunities about preconceptional counseling, we could have given some attention to reducing, controlling, and then the patient may have got pregnant? That is what we would like to know from you.
Dr. Surekha, I think we have failed our communities and our patients as gynecologists and as obstetricians as well. The concept of pre-pregnancy care or pre-pregnancy counseling is almost missing in our setup, in our population. That includes our government setup also. This idea or this very important aspect of pregnancy, of a planned pregnancy, has not still dawned on our population, especially in we are still a third world country. Here we have failed our patients and our population. This even in our referral centers, in our tertiary care centers, this concept of pre-pregnancy clinics and pre-pregnancy care is missing. Definitely,
this patient, madam, was of PCOS, right? And she must have been in follow-up with VAS only. So before she conceived, we may have, we should have counseled to pay attention about the weight control. We could have, she should have,
She
been
was
advised of contraception.
PCOS, but whether she was she was educated, she was aware, whether she, was somehow counseled by her gynecologist that if she is planning a pregnancy, she has these problems which may happen, that she is at increased risk of developing gestational diabetes mellitus or hyperglycemia in pregnancy. That depends on that. That means any patient, whether we are saying PCOS or for that matter, any patient who has hyperglycemia before pregnancy also need to have proper pre-pregnancy care, and her blood sugars need to come to be normalized, and then she may be asked to plan a pregnancy so that her chances of developing congenital anomalies of the baby and other complications are minimized. But that part, it's
I do agree with you, ma'am, that we do have to look into this, that optimization of the glycemic control, her weight, then looking into the contraception, because she has an unplanned pregnancy. So that is what I think that has led to all these problems. And thus we come to your question, madam. Again, see, the age is wrong in this patient. It's 32-year-old. She had a previous child of 3.9 kg. 11 years later, with a high BMI, she has come to you at 12 weeks of gestation. Now you did a single test, 248, again a high HbA1c. Now, what about, what do you think in this case also? What's your opinion that one baby previously 3.9, she has a 11 years gap, and then we have this kind of situation. What do you think about this situation? Again, missed opportunities.
Obviously, this patient has had previous large for dates or baby, and then there is a gap in between, a long gap. So as per the, if we go by the gestosis score also, she comes in a high risk group, and this patient should have been, advised to have her after delivery, after first delivery only, to be on proper medical supervision, because she could be a case of a patient who could develop just diabetes or hyperglycemia without even pregnancy. And then accordingly, this blood, if she was diabetic, this blood sugar should have been first controlled, and then she should have been counseled about having a pregnancy or venturing into a pregnancy. First, prior to that, her blood sugar should have been controlled first.
Yes, Dr. Shena. So both the cases, I think the take-home message is that these women who are, the previous child is through 3.9. So now in between also they could be having the impaired glucose tolerance, and that is where I think we need to have a close follow-up. And before they embark on the next pregnancy, we have to control the glycemic control, the weight, and then only probably. So that is where I think we should all now take proactive steps for the preconceptional counseling in our patients. So we now have this patient.
One thing I would like to add, Dr. Surekha, is that we have to establish pre-pregnancy clinics, pre-pregnancy care clinics, especially in our tertiary care centers. This should be a part of our routine, which is missing, which is so many
I agree, even
could be prevented.
I think
probably because of the large volume of cases which we deal with, what we are doing is we are cursorily, you're looking at the patient in 5 minutes, and we are missing on that important part of the preconceptional counseling. And I think the good take-home point and good recommendation from you, Dr. Shehnaz, is that we need to have these preconceptional counseling clinics with us.
This is very important because more and more women are venturing into pregnancy at an advanced age. And now that this hyperglycemia is becoming rampant, so it becomes very important that we not only this, but because of the age, the chromosomal abnormalities of the babies, the hypertension, the preeclamptic toxemia, this has to be part of pre-pregnancy care clinics, should be a part of every tertiary care unit.
I would like to add something, Dr. Shehnaz.
Yes,
I would like to add. I think we should even not only think of preconception counseling, it's a very important that we consider the pregnancy itself as a window of opportunity. Her previous pregnancy has given us a hint. It's her baby, herself, or leave alone the next pregnancy, which are all going to be at risk in future. So continuing on her postpartum care also is very, very important.
Right.
So at
Very
that point of time, we should have.
Yeah, we are going to come to that in the panel.
Okay.
So let's, I think, move on to the case 2, which now this patient has come very late. You know, she's a multi-gravida, again a 3.5 kg previous baby. 30 weeks she has come to with booking for us, and now we are having a high blood sugar on OGTT. So again, my question is to Dr. Archana. Ma'am, what next for this patient? She is coming with you quite late in pregnancy, whatever the problems has already occurred. So how do you now manage this patient? Do you want to refer to a diabetologist? Do you want to start insulin? How do you monitor? What are our target sugars? Dr. Archana.
Both the things will go side by side. I mean, immediately, as early as possible, next day itself, fasting postprandial will take, and glycosylated HB we have to do in this case. Plus urine and routine examination, everything we have to do in this case. Next, diabetologist opinion, if possible, immediately we have to take. In case not possible, then also we have to start her on insulin. Depending upon her fasting and postprandial level, we have to combine the long-acting insulin with rapid-acting insulin so that the balance is maintained. And blood sugar has to be monitored in this case very regularly. It should be ideally, if fasting, then after 3 meals, and then in the meal just before sleeping, if can be managed best. Continuous glucose monitoring, self-ambulatory glucose monitoring, all these things are good, but it should be monitored, because if she is unbooked case, I will say that it is better to admit and do all the blood sugar and then check it. Coming to the insulin level, insulin, we should go immediately for insulin, as earlier days we were giving regular and long-acting insulin. At present, we are having Lispro, Aspart, and Detromir. The advantage is that rapid action doesn't cause the hypoglycemia, which was seen with the long-acting insulin, which we were using earlier. So these are better, and they are given by pen. So method of giving also is easier. But still, there are certain disadvantages that still we have to monitor, and we have to counsel the patient, and the cost incurred for the newer insulin is slightly high than the available insulin. So it may not be possible for all the patients, but if it is possible, definitely. And if it is possible for continuous glucose monitoring, we have to see that it is doctor monitored rather than patient monitored. Just like that Dr. Atul Munshi sir said, that awareness, the patient acceptance is also a problem. Sometimes they feel that everything is fine and slightly ignored, maybe because mango khaya tha or something like that, they will describe. So it is always better to be monitored by the physician rather than completely monitoring it.
Dr. Krishna.
Then coming to fructosamine, it is good, particularly in a patient who is already anemic, or she is having any combined factor of liver disorder or sickle cell or hemolytic anemia. But in our cases also, because they are severely anemic, many of the patients, so it is better, if possible, we can do fructosamine. 1,5-anhydroglycitol we are not doing at present for pregnant patients. And glycated albumin, in certain cases, definitely it helps, particularly for short monitoring rather than for 3 weeks, but for 24 hours and all, it helps, and 2 weeks, it helps a lot.
Yeah, Dr. Krishna Kumari, your opinion.
Yeah, these I think where the pitfalls of HbA1c we all know, especially when the patients are anemic and when there is physiological dilution. I think this newer tests which are coming up would overcome those. I personally like to do HbA1c when there is a blood sugar are high in the very early weeks of pregnancy, because that is an indicator of periconceptional control, which would give me an indication about what the risk for chromosomal anomalies is. So now we already, macrosomia has already might have happened. We can't do anything about it. So usually later in a pregnancy, I normally won't do a HbA1c, but now with the newer sugar, with the newer test, maybe it would be a different call that would be coming up later.
Yeah. So we start insulin, we monitor the patient very closely. Probably she's going to need an admission with you. What we do is, titrate. We start with maybe the 444 or 666 units at rapid, and after 48 hours, we'll repeat the fasting and postprandial. We'll titrate with it. We'll have a good control. Our targets would be 90 fasting and 120 postprandial, and accordingly we'll monitor the patient and we will decide. That is what I think are the take-home messages. What about the fetal surveillance, Dr. Manasa? What about the Dopplers? How closely you will be doing, frequently you will be in the ultrasound? Do you think you can predict stillbirths in these patients, Dr. Manasa?
Yes, ma'am. Regarding in this case, as she is booked at 30 weeks, I would like to do a baseline scan at 30 weeks for the fetal anomaly scan and everything, and fetal Doppler also in this patient, because she came to us at 30 weeks. And regarding hospitalization, as she is the first visit to our hospital, I would like to detail investigations regarding her fasting and post-lunch, and even her urinary parameters and everything. I want to just hospitalize for at least 24 to 48 hours. Coming to fetal movement count, yeah, really it has a role in case of DDM or PGDM. In regard comes to ultrasound, the frequency may be 3 to 4 weeks, every maybe 32 weeks, 36 weeks, and depends on the delivery, so that we can see any abnormality in the fetal growth, either in the fetal growth restriction or macrosomia, whether she's setting the macrosomia. Surveillance, the best surveillance, actually there are so many methods, but in case of diabetes or PGDM, we can go with weekly or bi-weekly NST, and every 3 to 4 weeks fetal Doppler. Can we predict stillbirth in GDM or PGDM? I can say no, because in case of gestational diabetes or PGDM, there is alteration in the metabolic pH of the baby, fetal blood actually, and even in case of IUG or FGR, there is a redistribution of the blood flow in umbilical and MCA. But in case of GDM babies, even despite the normal Doppler, there will be acidosis and altered well pH of fetus, so they can have a stillbirth in GDM. So we can't predict in stillbirth in case of uncontrolled or suboptimal control of maternal glycemia of pre-GDM.
Yeah, definitely, madam. This patient, as you rightly said, needs a close monitoring. And as far as the stillbirths are concerned, even with good glycemic control, we are seeing that we may have some problems in these patients. And that's why, apart from close follow-up of this patient, good counseling is also very important. And as you have rightly said, that we do see redistribution in normal patients or non-diabetics. But in these patients, there may be some acidemia, and normal Dopplers we may be seeing. So Dopplers are many a times misleading. Of course, we have to counsel our patient about fetal kick count, and we really have to be very alert when we are talking of these patients of GDM. Dr. Sabita, what about the fetal weight estimation? Do you think it is very optimal? Can you rely on it? Any other way? What about clinical? How do you go about it as far as the weight is concerned?
Yes, ma'am.
Sabita?
Yes, ma'am. I would say that clinical would combined with the ultrasound will be better, because the sensitivity with the ultrasound guided macrosomia detection will be only a 50%, and most of the times around 26%. Overestimation may lead to unnecessary cesarean sections, and so clinical palpation and most of the times combined with the ultrasound guided weight estimation would be better. And this abdominal circumference will give a abdominal circumference of more than 90th percentile will predict the macrosomia, and we can alert the mother to have strict glycemic control so that the weight of the baby can be reduced. And as the growth charts are more important, not a single diagnosis of more than 90th percentile of abdominal circumference. And the 4th week, when you do it after 4 weeks. The CRO charts helps in the detection of macrosomia more than a single recording. And the difference.
Yeah, very nicely put. I think we should make a habit of looking at the growth charts and the percentiles. And that is where actually we fail. We just look at one point of time, but what about the trend? The trend is important, and especially the abdominal circumference will tell us which percentile it is lying. Is there a good glycemic control? Can be very well judged clinically. If there is polyhydramnios, that also will tell us there's poor glycemic control, and clinically and ultrasound both are important, because many a times, the sensitivity is only 56% as far as ultrasound is concerned. There is also inter-observer and intra-observer variability as ultrasound is concerned. So we have to be very careful when you're judging. But yes, a good sonologist can still give you a fair amount of idea of whether there is a good glycemic control or not. So, Dr. Rashmi, what about steroids? Do you want to give this patient steroids? Do you want to give it routinely, or are there certain indications? What about, would you hospitalize this patient when you're giving steroids? What do you say? Dr. Rashmi is there?
So, because we always say that there is a definite deficit in lung maturity when it comes to a fetus of a GDM mother. And administering steroids is a necessity in all, I think, in all the patients of GDM. We can definitely give steroids. We can titrate the dose of insulin if we are afraid that it might increase the levels of sugar. We can really admit her for a day, titrate the levels, increase the dose of insulin. But for the betterment and lung maturity of the fetus, it's a very good practice to routinely administer steroids in all the patients of GDM.
Do you think there may be some disagreement here? Dr. Krishna Kumari, what do you say? All patients, would you give steroids?
No, all those patients where we are predicting that there is going to be a risk of premature labor, yes, I would give steroids, but not for every patient as a routine giving. And another important one thing which has been said is that giving dexamethasone in lower boluses, because we give it at a lower dosage, that is causes lesser increase in sugar levels when compared to the betamethasone. And of course, there have been some studies where they have used prophylactically metformin and insulin, predicting that there is going to be, but there is no consolidated guideline to guide us. So yes, I would admit the patient who are all at high risk of delivering before they're where we are expecting the risk to be higher. And I would be closely monitoring, usually for 72 hours, although they say it can be high even up to 5 days.
So we have the Peppernick score. The Peppernick score is there to predict the preterm labor, and those who are having threatened preterm, I think these are the ones who will require the steroids for the lung maturity. But I think the point well taken from Rashmi is that even if the patient is 36 weeks or 37 weeks, usually we, for non-diabetics, we would say that 34 weeks is enough. After that, there is no need of steroid. But for diabetics, I think even at 36 weeks and the 37 week may need, these are the ones who will need the steroid. So that is what I think Dr. Rashmi was saying. And I would like myself personally to admit the patient, because what happens, the insulin requirement will increase in these patients, and we have to monitor their insulin requirements, and probably that is where the hospitalization may be needed. And then once you have given that steroid, and you may go back to the pre-steroid dose of the insulin for these patients, and then we can go ahead. So we now we have another patient, the third case. She's a 39-year-old. She's an IVF pregnancy. Again, the BMI is high, but her first visit is showing the OGTT of 160. She was started on insulin. However, she refused for some reason. Again, I think that this can be taken by Dr. Krishna Kumari. Would you give oral hypoglycemic in first trimester? We already have a lot of, already Dr. Mitra has talked about it. So probably we can skip this question also, because we have agreed that we can give the oral hypoglycemics in this patient. And this is the Government of India guideline, which Dr. Kiranmai has said that yes, it can be given in the first trimester, and it is actually chosen as the drug of choice prior to insulin also. So Dr. Shehnaz, this patient is this for you, 32-weeker. She maintains her sugar on strict diet, but the sugars are also in target range. Her blood pressure, however, is risen 150/100. And the scan is showing a small for gestational age. What do you do for this patient now? How do you monitor when to deliver? Dr. Shehnaz? Yeah, we saw Dr. Shehnaz was there, right? Probably some problem with the... So Dr. Krishna Kumari, again, we follow on your expert opinion.
Yeah, so she's a 32-weeker and the sugars
blood pressure is rising. Yeah, blood sugars are in control.
I would, if the scan is showing SGA, I would treat her like I would treat a case of preeclampsia. Yes, I would admit her and closely monitor here Dopplers. Your previous question on whether how Dopplers work now will come in, and Dopplers are done when you are having associated preeclampsia with GDM, especially when they're associated with SGA, and delivery would be anytime after 37 weeks, just like I would do a preeclampsia, and I won't wait till 39 completed weeks if there is a risk of the blood pressures rising. Definitely, yes.
Yeah, so we monitor, and this is the guidelines. If the patient is well controlled, GDM, no other comorbidity, it's alone, even maybe on the medical nutrition therapy or the insulin, the well control is there, then you can go up to 39 weeks and induce the patient, but you have to take care of, what is the estimated fetal weight and all those things. Now, if it is a poorly controlled gestational diabetes mellitus, if there is hypertensive disorders, if there's a previous history of IUFD, these are the patients you have to be very careful. You have to individualize what gestation. In fact, it is advised that those patients who have had IUFD, we may have to terminate 1 week prior to the prior incidence of IUFD, so that we know we can avoid the mishaps. If it is poorly controlled, if the baby's weight is, nearing 4 kg or something, maybe we'll have to terminate earlier. That itself indicates that the glycemic control is poor. And if it is fetal macrosomia, we may have to go ahead with a cesarean section at 39 weeks of gestation. So those are the take-home messages. Dr. Archana, this is the patient who has now come to you in labor at 37 weeks of gestation. In brief, I would just have few points from you for intrapartum management and neonatal complications. Dr. Archana.
I will first say that I am lucky that she has gone for spontaneous labor rather than me deciding when to induce. So she has come for spontaneous labor. So only thing immediately I have to get the blood sugar done. And if the blood sugar is under control, then I won't start insulin. Only IV fluid will manage. And if it is, say, lesser than 100 and 120, then we can just give normal saline. But if it is too high, then definitely we have to start insulin depending upon her blood sugar level, which can be 1 to 2 units per 0.25 units per body weight, depending upon what blood sugar she is having. Then coming to the neonatal complications. Neonatal complications as such, one of the most frequently is respiratory distress, what immediately we see for many of the patients in spite of taking betnisol or dexamethasone. Then also these patients may have slightly increased chances of having babies with neonatal respiratory distress. So I will always inform the neonatologist or the pediatrician, whoever is available, that they have to be there at the time for the delivery. Second is these babies are having more prone for hypoglycemia. Neonatal hypoglycemia is one of the major cause, and sometimes we lose baby also. So monitoring of blood sugar is very important for the babies as well. Next comes the hyperbilirubinemia, and sometimes in the certain cases, if they are premature, they may have a chance of needing phototherapy also. So, and second is these patients have, if particularly uncontrolled diabetes, these patients, babies will be in neonatal setup for a long time, and chances of getting infection is also high. So in case the patient was having PRM or anything, it is important that we are giving prophylactic antibiotics to mother so that the baby is not having immediate infection. And obviously we have to take care in the neonatal period also. So these are
the so we should have a neonatologist with us. That's the take-home message, I think. Yeah, and good glycemic control during labor also.
We have to monitor, and maybe many of the patients, in spite of spontaneous progress, sometimes they may have a high risk of going for cesarean. Shoulder dystocia, if the blood sugar was not under control, there is a chance of getting a shoulder dystocia. Then the PPH, which may be an obvious complication of the big baby or the diabetic, and maybe because of the preeclampsia, they may have a hemoconcentration, little bit blood loss also may cause PPH. So,
so we have to be alert for all those complications. That's very nice. And there's good team you should have, which you can monitor your patient. Electronic fetal monitoring, I think, will come handy in these patients who to detect hypoxia in the fetuses. You have to have good control of the sugars. That should be around 100 during labor. If it is a if the patient was on insulin, you have to stop the insulin dose in the prior night, and in the morning, if you usually would like to induce this patient has already gone in labor, so that's very good. As Dr. Archana has rightly said, you have to do the sugars, you have to find out if there is any need of the glucose insulin drip, and of course good control is needed, and you have to be alert for any complications, and you need to have your neonatologist who will be attending this labor. What about the timing of delivery? It matters a lot in this patient. And Dr. Mansa, what about early terminations? Do you think if early, how early? What are the benefits? What are the risks of early termination?
I think, Madam, our previous slide has been covered regarding this. A well-controlled, optimal controlled diabetes, we can wait up to 39 weeks, 39 to 40 weeks. Also, we can induce or we can plan according to the obstetric indication for C-section. In case of any complications, maternal or any fetal complications arises, we can plan accordingly. It depends on the gestational age. If it is well controlled, I always say like 39 weeks we can wait. If it is complications are there, we can like induce or we can do C-section according to the obstetric indication. Depends on the gestational age.
Yeah, definitely. I think the take-home messages have been clear throughout the panel that depends on the glycemic control of the patient, and you can take the patient up to 38 to 39 weeks of gestation, because if you terminate too early, the iatrogenic prematurity is there. But sometimes if the patient have previous IUFD, that is where I think you need to take a call on when to terminate the pregnancy. If it's a macrosomia already there, glycemic control is not there, that is where I think you need to take a call on when to. And of course, if there are comorbidities, is the preeclampsia and all are there associated, then again, depending on what is the associated comorbidity, you'll have to. And if you prolong for too much, then you'll have a big baby and increases cesarean section rates. And sometimes, the birth complications and birth injuries may happen in these patients. Dr. Sabita, I think we have talked about vaginal delivery versus C-section. What is your brief, final take-home message about this?
Only if there is a macrosomia and poorly controlled diabetes, we have to go for the cesarean section. In well-controlled cases, until there is an obstetric indication for a cesarean delivery, we can induce her and we can go for the vaginal delivery.
Dr. Krishnakumari, your take. We think our obstetricians are afraid of vaginal delivery for these patients. What do you say?
So diabetes is definitely not an indication for C-section. It is any other obstetric any other obstetric indications. Yes, you may take it up, but per se, diabetes per se.
But lot of difference, I think, we find in practice as far as maybe the private and the public sectors are concerned. But let us give this take-home message that gestational diabetes does not mean a cesarean section. In fact, when controlled gestational only on medical nutrition therapy, also we have patients who can very well be delivered. Of course, we have to be alert. like all patients, these patients also, we have quite a few patients which we induce and we can go for vaginal delivery depending on what that case is.
One important thing is, I think, the skills and drills. The younger generation, the people who are taking up obstetrics should be trained for management of shoulder dystocia. When we were, we had been trained, and now the same thing is not being passed on to the next gen. So training them for shoulder dystocia, management of shoulder dystocia will take a long way, will give them a lot of confidence. I think that's what scares them from doing a normal vaginal delivery.
They are always afraid that there will be a shoulder dystocia which they will not be able to manage. Rashmi, what about the third stage? Are you afraid for the third stage? Any practical tips for these patients?
Active management of the third stage of the labor. That is very essential. Preparedness for PPH, preparedness for subinvolutions, and preparedness for infections. That are, I think, most important factors when managing the third stage of the labor, especially management of.
Yes. So you agree that you can give carbitocin to this patient. These are the patients who we can keep carbitocin as in our armamentarium. You should be looking. You should be alert for any tears, vaginal tears. These patients the babies are large, so you have to be careful. You have to be alert. You have to take prophylactic steps so that there should not be PPH. And of course, as Madam has rightly said,
important is initiating breastfeeding as soon as after the birth of the baby.
Okay, so this advice I think Dr. Kiran was supposed to give, but I rely on you to please complete the postpartum care of this patient.
So the most important thing is as soon as the birth of the baby is there, we should initiate breastfeeding. Why? Because it will drastically reduce the need of insulin in a mother. It will reduce the blood sugar levels and also take care of baby's glycemic status and prevent baby having hypoglycemia. Then we can at the time of discharge and at the time of at the 6 weeks we can really do the blood sugar testings for this patient, and accordingly we adjust the doses of insulin. So now what happens that in our scenario, the patients are very much reluctant. Even the educated patients, they are very reluctant in the postpartum phase for follow. So that's a very difficult thing. But we can take the help of SMS, phone calls, technologies, and education. And we can here at this stage, we can get associated with our fellow pediatricians, because when the mother will come to the pediatrician for vaccines and follow-up of the baby, we can really put down the note to the pediatrician that whenever the child or the neonate comes to the pediatrician for vaccines and follow-up, please that doctor should ask the mother that you had GDM, have you visited your gynecologist, and have you checked your sugars, and if there is real need of insulin or other hypoglycemic agent that can be done and get corrected.
Very rightly said. I think Rashmi is putting across very nice points when she's talking about taking in the help of pediatrician, because the baby is going to come to the pediatrician. That is where I think the window of opportunity is there for all of us. So as Dr. Shahnaz is not there, I'd like Dr. Krishna Kumari to talk about the long-term consequences and how we can bridge that gap of care which is not probably being given to our patient, as Dr. Shahnaz has already pointed out about the preconceptional counseling. What about the postpartum and the long-term follow-up of these patients?
Yeah, the postpartum follow-up of these patients is very, very important, not only from the mother's point of view, but also from the newborn point of view, because the consequences are going to be there for both of them, whether it is the mother developing type 2 diabetes much later in life, or whether she's going to have a higher risk for developing cardiovascular diseases, including malignancies. Some malignancies like breast cancer, pancreatic cancer. Then there are, of course, ophthalmic issues that might come up. The renal issues might come up. So many things that it is a time for us. I always say that women have this opportunity of picking up their diseases early during their pregnancy. So what their future health is going to be. So that can be to some extent predicted in pregnancy. And so I think we should take this period, whether it is the first 3 months or 6 months after delivery, we should never let the woman go. Not only that, the fetus also. These babies.
The baby has to be followed up also, because I think the type 2 diabetes is more, they are prone to. And the dyslipidemia and the cardiovascular risk rises for the mother also. So that is where I think we can counsel her about her lifestyle, about her food, diet, what type of pattern she is having. Is she's taking a lot of carbohydrate, low on protein? All those, I think that these are the window of opportunities for all of us, so that all of us can pitch in and reduce not only the diabetes related complication and morbidity in the pregnant woman, but later on in life also all these complications related to diabetes mellitus per se, cardiovascular risks, dyslipidemias, hypertension. So all those things which can be prevented, and we can play a great role in the women's health as a gynecologist obstetrician who's been dealing with her pregnancy and throughout her life who is following up with her. So great take-home messages from all our esteemed panelists. I thank you for those messages. And yes, we have to detect early, take the pehla kadam. All our mothers have to be screened so that and any pre-existing diabetes is there should be reduced prior to the patient getting pregnant, diagnose early, follow up closely, monitor the patient well, keep a good control on the glucose level during pregnancy, and of course the postpartum breastfeeding, as Dr. Rashmi has very rightly said, take the help of your pediatrician, follow up with the patient well. After 48 hours and 6 weeks, maybe we should monitor. And as Dr. Krishna Kumari has said, the first 3 months and the 6 months are the ones where we should be in close follow-up, so that, and of course, good contraceptive advice, so that there should not be any unplanned pregnancies in these patients, and they should. And Dr. Shahnaz has given a very nice recommendation that we should have a preconceptional counseling clinic, even in our large volume setups. So with that, I think we come to an end of this wonderful session on hyperglycemia in pregnancy, with great take-home messages from experts. And we have really had a good discussion and interaction with this case base. And thank you very much for all of you for joining with us. Over to you, Dr. Rashmi. I think Dr. Supriya is also there. Would you like to say something, Dr. Supriya? What about diabetes in your own setup? And would you like to say something?
Dr. Supriya, are you there?
Yes, she's there.
Yeah, I'm there. So good evening, everyone. Actually, I apologize because I couldn't join in time because we had a condolence meeting at our place. So
yeah, Dr. Chakraborty,
I had heard all the discussions. It was very good, and it is very much prevalent in our place also. And the way you have discussed about the treatment, the precautions, what we should take, and pre-conception counseling. So we all do accordingly, and very well taken care of. This diabetes is very important, and we should take care of the morbidity and mortality in that case. Thank you.
Thank you very much. Thank you, Supriya, for joining with us, and thank you, Dr. All the esteemed faculty for being with us. And I hope that all the participants have benefited with the discussion. Over to you, Rashmi, for the concluding remarks and the vote of thanks.
Thank you, Surekha, and wish all of you all the best. Thank you.
Thank you so much. Thank you, Krishna.
At this point, I would like to mention that Dr. Surekha Taide is she's contesting for the post of chairperson of Clinical Research Committee. She's an apt candidate for that, with a great, huge experience in research and immense work in women welfare. So I would like to request all of you to kindly vote for her.
Thank you, Rashmi, for that vote appeal from my side, and my personal request to kindly vote for me. 21st of April, you will be getting the link on your mails. Thank you so much. And all the esteemed faculty.
Yes,
Rashmi, please go ahead.
Thankful to all respected faculty, chairpersons, experts, our special guest, Dr. Supriya Jaiswal, madam, all the dignitaries, all the respected panelists. Thank you very much. It was really very wonderful to have all of you with us today. Thank you so much. And we are especially thankful to COR-CONNECT Corona Remedies for this flawless and excellent conduction of this webinar. Special thanks to Abhishek Shah, Nisha Thakur, Vasu sir, and Bashish. Thank you very much. So we would like to
have a great evening and have a good dinner, all of you. Supriya is also contesting for our Adolescent Health Committee. So please support. Thank you very much.
Thank
See
you
you
and all
again.
the best, Dr. Surekha.
And Dr.
Thank you, Dr. Archana. Thank you so much. Thank you. See you again. Bye.
I also
Thank you, Savita ji. Thank you, Manasa. You spoke
See
really
you
well.
all of you again in some other webinar.
Yeah, Manasa and Sabita, nice to make friends with you. Dr. Aruna, Kiranmai, Dr. Meika, and Supriya. And special thanks to Rashmi, my very dear friend. And of course, she takes ISOPAR to greater heights. Thank you so much.
Thank you.
Good night.